Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. Levanova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. Levanova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the Levanova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The Levanova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
We need a new picture of John. Hello, everyone. Good afternoon, and welcome to PerfWeb 40, our fourth Journal Club program. Tammy Sparacino Journal Club program. Tammy's here with me. Nice to see you again, Tammy. You'll see a picture of her later when they bring it up, but right now they have everything offset, so I can tell you to check out our sponsors. Very important. So please click them. Let them know that you're watching through us. Tell your reps, do anything you can to help us, and suggest some new sponsors. Tell them how much you like and watch this program so they will call us and help us keep all of these lights on. It would be greatly appreciated. Check our social media. Like us, follow us, share us on Facebook, the Tweeters, the LinkedIn, and the YouTube. Make sure you give us the thumbs up, click the subscribe button and the bell notification so that you can find out when we're going live for whatever reason it may be, or we're adding new content, because we're going to be adding about 100+ hours of new SDCE content. Board probably get mad at me for saying that because I haven't sent the application in yet, but you're going to be really surprised at how much more content is coming your way for you to earn those all-important 45 credits that you need, CEUs, through the ABCP for our, I guess, what is it, triannual? Triannual, is triannual the right word? No, because that biannual would be twice a year. Mm-hmm. Every 3 years, let me just say it that way, simple. Check out our websites, perfweb.us and perfusioneducation.com. Join our faculty, check those sites out. And also, when you see this symbol, it'll be that our call-in number and the phone lines are open. Oh, nice. You did that in a new color for the Tammy Sparacino Journal Club. I like that. Nice graphics, David. Thank you. Okay, so we're going to just jump right into the show. Tammy Sparacino, you all know her. Welcome to the show. You've got an article to do, but can I ask your permission to ask a question about my today's set of events, but not necessarily getting into the weeds with the events?
Yes.
Okay. John, hey, John Ingram from Florida. John, thank God you're here. We're going to have a good show. Man, it's great to see you. I've got like we are the team. We are PerfWeb now. This is PerfWeb, okay? So I wanted to ask you guys this question. You got to help me understand it. I won't say where, but I was in a COVID unit, taking care of multiple ECMOs on multiple patients, and we were going to transfer, we were going to transport one of the patients to another department for a procedure and then back. And the unit and the department that we had to go to are on the exact opposite sides of what is an enormous facility. And it's 2 elevator rides on top of it. Now, to go into the patient's room, we had to get all garbed up with PPE stuff. And then to come out of the patient's room with the patient, we had to take all of that off. And then we all went down the hallway, through the corridors, down an elevator, across the entirety of the facility, making multiple turns to another set of elevators, to another floor, and then back out to the facility and making several more turns, eventually arriving at our destination. Upon reaching our destination, I then had to garb back up in what I'm going to term Uber PPE. It was PPE on steroids this time. It wasn't a PAPR suit. It was an unventilated triple layer with 2 masks, a hood, a hat and a hood, and goggles, to the point that somebody was telling me, asking me if I felt okay, and I wasn't feeling great, but I thought I was okay, but they said you're like turning purple. So
you couldn't breathe.
I was smurfing. So I sort of finagled my N95 down under my nose and started like hyperventilating myself. I looked at my fingers. My fingertips were all blanched out. There was almost no discernible capillary refill. Now, what I need to ask is, because they all went through the same process going the other direction, we never put the patient in a bubble. We didn't change any of the equipment or UV it. The bed didn't get UV. We didn't change the bed when we left the one unit to go there, and we just went all through the hospital. I don't get it. I don't understand it. What am I missing about the way we are managing this? In other words, it seems to me this is being done to just CYA as opposed to anything truly effective or reasonably doable, to where you're not perhaps causing an environment that is less than optimal, to where you're not operating at the right level to be taking care of these very sick people. What am I missing?
Joe, let me ask you a question. Welcome to my world. I do trips like that to other parts of the department with COVID patients 2-3 times a day, and they are an absolute gigantic adventure. Not only do we have to go to the other side of the facility, the 2 buildings that internally attach are not equal, so you go up and down very large ramps as well as what you just said. So let me ask you a question. How much PPE did you wear when you were going down the hallway, and did you pass regular passerbys, patients and everything, going the opposite way as if it was a normal patient?
Patients, not that I'm aware of, but multiple employees. In fact, we had to actually like beckon people to move various pieces of equipment and other obstacles that we couldn't get around, including floor buffers. So I'm just trying to understand.
You're passing down as you're walking down the hallway, the patient's not in a bubble. You don't have all of your PPE.
I don't have any.
When you magically
I had
arrive
none. I had zero.
at the destination, right? When you magically arrive at the destination, suddenly you have to put on multiple layers of PPE all of a sudden.
Yes.
Mm-hmm.
And that happens to you too?
Oh, this is exactly what we do.
But why are we doing this?
Well,
Every day you do the same thing.
is it
And let me
because
say
you're
this.
going to have a procedure done? So you weren't doing a procedure when you were transporting?
Okay, it wasn't an airway procedure.
Okay. I don't know. I was working at another hospital, and they were transporting a COVID positive patient to come have a procedure done, not ECMO, but I was going to be there for the procedure. And
So a standby.
yes, a standby. And it's a small hospital. To get the patient from the COVID unit to the approved operating room where we're doing COVID patients, they closed down all hallways, and security escorted the transporters, the nurse and patient, all the way to the operating room. So they were clearing the hallways, but you're right, no PPE was worn other than a mask.
Yeah, well, I did have a face mask on, a regular face mask, not an N95. That is true.
And then
but
once we got into the room, I was just waiting. Once I was in the room, I wasn't allowed to leave the room, even though I was just doing standby, and we were in an operating room that we typically don't do cardiac procedures in. So all the equipment wasn't there, and so we kept having to say, oh, we need this, and could you get that? And at one point, our little runner person was not available. They had to run across the hospital to get something. So I popped my head out because that's where our cart of supplies were, and I just grabbed something for the table. And then someone saw me and said, you can't leave the room. You're in the room.
I mean, really?
Yeah.
Really?
The patient, yeah. So
This is
Joe, you ever heard that story, the emperor has no clothes?
Oh, very,
Depending
yes.
on what day it is, what department you're in, who is the general overseer, power broker in the room who decides you must change your gown before leaving and put on another gown. Other times you wear the same gown. Sometimes you wear no gown. Sometimes it's double gloves. Sometimes it's one gloves. Sometimes you have to wash. Sometimes you don't. And then when you get to another department, the rules could all be different. But what Tammy was just saying, when we first started, security came and locked down. Every patient's room door had to be closed. Every hallway had to be clear for the entire pathway. Now it's all doors open, passerbys come in the other way, family members, other patients that may or may not even have COVID, and we're just cruising by. We have our masks on. And maybe gloves and gown, depends on the day. Off we go.
You have family visitors?
One family per patient, yeah.
Oh.
We have none.
Well, unless
they're at end of life.
Yeah, compassionate visit at the end. That's it.
I mean, in the regular part of the hospital where we have to walk through all these other areas that we have to walk through, they're allowed one family visitor. Not in the COVID unit. I think they have to do Skyping or FaceTime or something.
Okay.
Yeah. Well, even for most of our surgeries, they're not allowed a visitor.
No, we do regular standard heart surgery. They don't get a visitor.
Yeah.
No, absolutely
They're
not.
on lockdown.
They are. We're still on lockdown. Our numbers, I mean, the numbers in Texas are, in Florida too, I keep an eye on Florida, but they certainly are trending downward. The active cases are definitely trending downward. I can tell the units are looking less active, certainly on admissions.
We definitely have beds available in ICUs now.
But the ones that are already there are now in that cycle to where we've had a tremendous spike.
For us, personally.
Yes, for us. Yeah. In our group, we have had a tremendous spike. Right now we have 3, 6, 7. And I know you're in a big unit, but think about that in a community-based hospital that are not ECMO centers, right?
Yeah.
We had like almost 11 at one time. We had 5 and 4, that was 9, and 2, 10, 11. We had 11.
Well, we did 3 on Monday alone.
Yes, right. So, but I think that's from people that came in the hospital 2 weeks ago. I think that's about what we're seeing is a 2-week delay from, you know, time of admission, not necessarily time of infection.
Right.
Time of admission to when we're seeing them as far as being ECMO candidates, because I think people are still
they
really
slowly deteriorate up on the floor, and we have a trigger point, and when they trigger, they have to go on ECMO.
Yeah.
And you a couple weeks in the hospital, something like that.
Yeah, absolutely. Okay, go ahead. I'm sorry.
And then a good 3 weeks plus on the ECMO for COVID, if you're lucky.
Yeah.
Yeah, I don't know that ours are probably, you know, we're probably 14 to 17 days median.
Yeah.
I think we've had a
couple
we've
longer.
not had any 30 days, have we?
No, but we had one, I think about maybe 21 or 22 days.
Yeah.
Recently.
Yes.
But
yeah.
they didn't make it.
No, that one didn't. But ours, I think what we're seeing is if we don't get them off in probably within 14 to 7, certainly less than 20 days, longer than that, they may come off, but it seems that they're not, you know, the amount of damage is just too much. And usually the ones that we haven't had good success with have been the ones that have had delayed initiation of ECMO. The earlier initiation of ECMO, the sooner they can get that vent turned way down, the better off they are. If their lungs have been pounded by mechanical ventilation at full support for 7 and more days, even really 5 or more days, I haven't seen very promising results with that. You know, so with that said,
we're not talking about COVID.
we're not talking. That's right. Who brought this up?
That was you.
No, it was John. Okay, so let's get to our journal club.
Okay, so today we are going to be discussing acute kidney injury, and
Oh, I like that.
this, and John likes it, so
I like that.
yeah. This article was published in 2019 in the Journal of Cardiothoracic Surgery. It was, the title of it is Higher Arterial Pressure During Cardiopulmonary Bypass May Not Reduce the Risk of Acute Kidney Injury. It's by Cannula and colleagues. Okay, so here's the abstract. The background: acute kidney injury after cardiac surgery is common and associated with increased mortality. It's unknown whether an intended higher arterial pressure during cardiopulmonary bypass reduces the incidence of acute and chronic kidney injury. They have actually some pretty interesting results, and we'll go through it step by step here. Let's just talk about a little bit of background before we move on. The known factors that seem to contribute to the kidney injury are systemic inflammation response, microemboli, and hemodilution. And many studies have also indicated that the use of the heart-lung machine compared to off-pump beating heart surgery increase AKI. Okay, so this paper was published because the incidence of acute kidney injury is known to be high. You see varying numbers. We'll come across that when we get into the specific data a little bit later. But it's of great interest to people in cardiac surgery, specifically perfusionists, I think, because we want to make the bypass machine the least detrimental as possible. Okay, so the problem to be solved is whether or not mean arterial pressures have an effect on how the kidney handles being on bypass. Pretty basic. I think we've all kind of heard this, keep your pressures up. Okay, so their methods were 90 patients were enrolled in the study between May 2011 and December 2013. This took place in Copenhagen in Denmark. The inclusion and exclusion criteria They included all patients that were greater age of 70 years old and complex cardiac surgery, meaning a valve replacement and bypass surgery in combination. Exclusion criteria were serum creatinine greater than 200 micromoles per liter, any previous heart surgery, endocarditis, any acute operation defined as a coronary angiograph within less than 24 hours. It's a randomized study with a control group and a high pressure group. Their primary endpoint was to study the mean change in the GFR at follow-up compared to baseline. Their secondary endpoint was to measure the change in urinary neutrophil gelatinase associated lipocalin and the urinary creatinine ratios at different postoperative times compared to baseline. That particular method has been shown to be highly sensitive to predicting AKI. Okay, so let's get to their conclusions. First off, any differences were considered to be statistically significant with a p-value that was less than 0.05. All right, so let's get to their data. Looking at this table, you'll see I highlighted only one particular item, and that was the incidence of AKI. They tracked a lot of different things. None of it was statistically significant, so I just thought we'd narrow our focus to discuss the main focus of this. 35% of the patients in the study developed AKI. There were no differences found in the incidence between the two groups. 16 of the control group developed it, 19 of the high pressure group. 7 patients total received renal replacement therapy, which was about 9% of the control group and 7% of the high pressure group. So their overall conclusion was an intended arterial blood pressure of greater than 60 during a cardiopulmonary bypass did not seem to decrease the risk of acute or chronic injury in the patients. And cardiac surgery has generally resulted in a substantial loss of renal function measured at follow-up 4 months post-operatively. There were a few limitations to the study that should be mentioned. It was a very small group. They also had many patients drop out over the follow-up periods, and that made the cohort size relatively small that made it from start to finish. Okay, so that's our article. We can open it up to panel discussion. I'm sure John has lots of things that he would like to go over. I've got some interesting graphics for us to look at specifically on AKI that I think will be fun for discussion.
Very good. You may have said it, excuse me, COVID. What was this published?
2019.
2019. Yet there's, I mean, as I recall, there's some really good studies out there that support that on pump is no worse in AKI rates than off pump.
Yeah, this didn't.
I found that very interesting that they had that position. So I'm concerned that they didn't really review the data very well.
Well, I think what they said was there are a number of studies that have indicated they weren't necessarily saying that that was what their point of view was. It was just the background information that many studies have said on pump versus off pump does less damage.
Where are they from?
They are from Denmark.
Okay, now I understand.
Now you understand?
Now I understand.
Hold
Yes,
on,
that's the problem.
Why is that the problem?
Yes, we're right. They're anti-perfusion.
They are?
Yes, we are doing PLM. Perfusion lives matter. The pump is good for you.
They never said it wasn't.
Okay.
All right.
They implied it, as far as I'm concerned.
Well, I think they referenced 3 studies. One that was done, looks like in 2012, and another one that was done in 2009, and another one in 2010, all studies for off-pump versus on-pump, not specifically on AKI. Actually, one is specific about AKI, but the other two are just general. Yeah.
John, I'm gonna punt over to you. I think you're the expert
Yes.
here on this.
You know, we're the Journal Club purpose is not to critique the article, but we've all agreed that we can go down that just a little bit so that the audience can appreciate that we also appreciate the pluses and minuses of the article. So one thing I found interesting is that they collected the data from 2011 to 2013, but didn't publish it until 2019. So I'm not sure what took so long, but I think it was a good article. I wish the number of patients was twice that size, if I would have had my choice. And you're right, Tammy, they had a fair number that dropped off for the follow-up because some died and then some also were non-compliant, I think, and different reasons. So they did, I think they did, you know, a pretty good job with what they were trying to show. And then the other thing too is that, and I have sent in two slides to your engineer, Joe, because I wanted to be able to discuss something, and it helps to have a graphic. So if David could put up the first slide, I call it delivery of oxygen slide. I just have two slides, but it helps for the conversation. And if you notice in the article, they the other thing I thought was interesting, besides before I discussed this, was they called it not significant, but they had 38% of the control group that had AKI, and then they had the high pressure group that had 46% AKI, and they considered that not significant. Would you consider that significant? Sounds like a big difference to me.
Clinically, yes. Statistically, no.
The reason why it statistically wasn't significant was also because the smaller group, right?
Yes.
Yeah, they only had 45 in each group. That's a pretty small group.
Yeah, it's a small end.
Yeah,
So
the 3-patient difference, the difference between 16 and 19, so the percentage went skyrocketing up because of the small patient size.
Right.
But what's interesting too about the article is, you know, they actually reinforced the delivery of oxygen theory at the end, and I'm going to put up the next slide and bring a quote from the article, because what they start talking about in the end is they start referencing other articles like this one. So go ahead and put the slide back up to tell you about the delivery of oxygen. So in this part of the article, see what they say here. They reference, this is the last reference, is reference number 22 in their article by Landmeer, Impact of Cardiopulmonary Bypass on Renal Oxygenation in Patients Under Cardiac Surgery. And here's the quote directly from the paragraph in yellow there. They're talking about this study. The more direct approach of measuring renal function, they actually put a renal vein catheterization, suggested that a higher flow than 2.4 is beneficial for the kidneys. In fact, this article that they're referencing found that 2.7 and 3.0 index of flow improved renal oxygen supply and by 14 and 30% respectively. And it also says in the studies they talk about that the pressure during bypass has no influence on the incidence of AKI on a broad range of patients and procedures. So, you know, so if you put what they're saying is, they've completely gone away from the claim of whether or not pressure is beneficial or not, and basically have demonstrated here that flow is what matters a lot. And so if you could put up the other slide, David, and what you're talking about is delivering the oxygen. Put up that other slide, Dave, please.
yeah, it'll take them a second.
Okay, and so when you look at the delivery of oxygen formula, you notice that it has 4 variables. DO2 equals blood flow times the oxygen content of the blood. So if you go to the very bottom there, delivery of oxygen equals blood flow times 1.36 times hemoglobin. So what's in green is your variables that can change: blood flow, hemoglobin, saturation of oxygen, and PaO2. Nowhere in there is there a blood pressure of number for a calculation. So delivery of oxygen, and they just said that in the paragraph, that when you increase the blood flow, that studies have found that there was an increased delivery of oxygen to the tissue of the kidney. So I just thought that was really interesting. And their discussion, they talked about other articles that really reinforce a lot of things that we've talked about in previous lectures, and goes along with goal-directed perfusion and evidence-based medicine, where pressure is really not been shown to decrease AKI. It's about delivery.
Yes, agreed. And if you remember, now this is going back a long way, you may not remember, but Shumway, back in the late 70s and early 80s, ran their perfusion pressures at 30 millimeters of mercury, 30. And his reported outcomes did not demonstrate a higher incidence of renal failure. They didn't necessarily measure AKI, but renal failure to other centers around the country that ran them much higher. So that goes to your hypothesis that if all things are equal, now his stroke rate may have been different. There may be some other things that may have been affected, because I think at that pressure you probably lose autoregulation, but I think the kidney maintains autoregulation through probably all ranges of pressure, unless you have precapillary constriction. Then I think it's a different phenomenon, or outflow obstruction.
The other thing that I liked about the study was that they point out that their vasoconstrictor agent was norepinephrine, which anytime it's not phenylephrine, I'm happy.
Right. I actually highlighted that in the article because I wanted to make sure we made mention of that, since you talked so much about that.
Can I ask you, and you may have mentioned it also, and it's not that I hate to say, that I was paying attention, but I was distracted. How did they measure AKI?
Well, they used the, hold on, I'll get to it. So they used
the serum creatinine, a doubling of the serum creatinine?
Yeah, hold on one second. I'll read it to you exactly how they, okay. 12 to 17, hold on. I think I have that highlighted. They looked for difference in preoperative incidence of AKI. No, it was in there. Hold on just a second.
They used the rifle criteria.
Yeah, they used the rifle criteria.
They used rifle criteria.
Look at the NGAL to creatinine ratio.
Yes.
Which,
so they were measuring NGAL, because I don't think that many people measure NGAL. So they did measure NGAL.
Yeah, I'm pretty
which
sure.
Which is supposedly a more precise biomarker.
Right.
To AKI than is okay. So they used a pretty good thing. Yeah. But of course, you're also not taking into consideration perhaps the microcirculatory flow patterns. Was there any derangement? What were their flows? Did they use hypothermia and think that was renal protective? I think a lot of questions. I have more questions than I've been able to elucidate answers to necessarily from the study that would be helpful for me to know to really talk about their particular study. But I do think that I do agree with you, John, in that DO2 I think is the answer. But I think that's for everything. And I think that I don't want to circle back to COVID, and I hope everyone will forgive me for going back to COVID. But the lungs depend on the pulmonary artery and the pulmonary alveolar capillary flow for its oxygenation. And when you leave people so desaturated going through their pulmonary arterial system because of being on the vent and hypoxemia and high O2 extraction, because they're just they're running on the edge. The injury I think that's happening is a multitude of things, but I think oxygen deprivation to the lung tissue itself is a contributor. I think oxygen delivery is the key to almost everything.
I think that's going to emerge over the coming years more and more. It already has. But another thing I liked about...
Uh-oh.
Lost John.
One second, my lights went off in the room.
Oh, John, there you are. You're back.
It's
Oh,
on
the
a
lights
motion
went out?
detector, and I guess I was not moving around enough.
Yeah.
The good thing I liked about the article was it tried to use high-risk AKI patients, and they used patients over the age of 70. I kind of like that idea because if you just took random ages and you were operating on 50 and 60-year-olds, maybe they're not as vulnerable.
Right.
And so they tried to use a vulnerable class of people. And had they been able to do, another 90 patients, this really would have been a pretty impactful article. It is already, I think, because, they ran a 10-point higher pressure, basically, is what they tried to do. I think if you look, it says 47 plus or minus 5. So they were running 45 to 55, and then 60 plus or minus 5. And so they're running 55 to 65. And, on a high-risk group for, I think their bypass times were almost 2 hours. There's other insults that go along, a lot of other insults, that noxious insults, toxins to the kidneys, so many different variables we've discovered that cause AKI, but it does not appear, and I'm not a believer, that running a higher pressure is one of them. It just doesn't seem to bear out in any good study.
For AKI.
Yeah.
AKI, yeah.
But
maybe for other things.
For cerebral perfusion, I think the range is autoregulation is between 50 and 150, or 50 and 160, depending on, I guess, what you look at. So
I think autoregulation for renal is 75 to 160.
It's that high?
It's something like that. I have it somewhere in here.
I didn't realize. I thought
They
it was
say
much
that-
broader than
They
I
say
thought
that
it
in
was.
the article.
Yeah.
Tammy's right. They say that in the article with a pulsatile flow.
Right.
You get away from a pulsatile flow. That can't be it, because we don't run pressures near that high. So
Yeah.
You go from comparing apples to oranges because you get away from the pulsatile flow. Now a whole different physiology is coming to play.
Well, yeah, but and I don't want to go down a bunch of different rabbit holes, but if you'll indulge me, compared to preoperative physiology, we have, you're right, an acute loss of pulsatility and no way to truly deliver physiologic pulsatile flow without having ridiculous risk. So I don't even think you could do it with excessive risk. You can't get a physiologic pulse pressure with a pump that exists today. It's, in my view, impossible. And I'm confident I'm right. I'm frequently wrong, but never in doubt, just so you know.
I have a few graphics that we can click on and discuss.
Let's do that.
Okay.
Yeah.
So this is just a little review of the different causes of AKI, and I think it's a nice graphic. It kind of breaks it down into pre-renal, renal, and post-renal causes, and the classifications according to AKI should be considered under the different anatomic components of the kidney: vascular supply, tubular, interstitial disease, etc. Okay. And then this is an interesting study that I borrowed this graphic from. It's only in the hospital setting, the causes of AKI, and you can see that the most common cause is acute tubular necrosis. And this particular study was a 9-month study that was done in Madrid. It's older, from 1991 to 1992, and they looked at patients who only had about 748, I believe, that only had prior normal renal function. And then they measured that, they actually called it acute renal failure, and it was defined when the sudden rise in serum creatinine was of 177 micromoles per liter, and it was, it looks like, I think that was close to 50%. It was just under 50%. So I think that's pretty interesting too. Then, since they talk so much about the the specific cause, this is a good graphic that shows when you have tubular injury and the necrosis, where it occurs. Then this one is a great graphic showing the systemic effects of acute kidney injury. You know, it affects so many things, the liver, the gut, the heart, of course, the brain, the lungs, and even the bone marrow. So I think that's pretty interesting.
That's our organ crosstalk.
Yeah.
Seminar we had one time, Tammy. And,
yeah.
And so really, if people really want to go down a limb and learn some things that was rarely talked about in school, I think, and even in the field, that's a good graphic, and that reminded me of the organ crosstalk.
Yeah, we
did, which was really interesting.
Yeah, I do feel, and I don't want to interrupt you, but just I just want to say
jump
this very
in
quickly.
anytime.
I feel like, and I've said this for many years, I feel like the kidney is a grossly unappreciated organ by perfusion. We look at it for a very brief period of time. They made urine during the case. That's okay. They didn't make urine on the case. They'll do it later. And then we never really know what happened to that patient. And AKI rate's pretty high. Acute renal failure requiring lifelong dialysis, that's about 2.5%.
Yeah.
But AKI rates are somewhere between, reported between 25 and 38%.
Yeah, I actually have something about that coming up here.
So it's pretty high.
Okay, so here's, this is taken from a study that I thought was really interesting, actually. I found it after selecting the first article, but I really liked this article as well, and I just used it for some reference material. But this was an article published in Critical Care in 2016 by O'Neill and colleagues, and it was acute kidney injury following cardiac surgery, the current understanding and future directions. And so they did a very nice summary of the risk factors, any preoperative risk factors, your intraoperative and your postoperative. And these are all, all play a part in which patients are going to be at high risk to develop AKI. And then this was a really interesting graphic talking about, okay, so you developed AKI from cardiac surgery. What is the progression of this disease? How is it going to present itself if it continues on the same path? And you can see that we've got a 2 times higher risk once you get AKI to end up with chronic kidney disease, and a 16-fold risk if they get acute kidney disease to get chronic kidney disease.
That's huge.
That's huge. That's really huge. And from this particular article, the critical care article, these were the key points, which I thought were really eye-opening for all the things we've been talking about. 30% of cardiac surgery patients develop acute kidney injury to some extent. The injuries, of course, impair functions of the brain, the lungs, and the gut. They have a 5-fold increase for risk of death during hospitalization. It will cause renal ischemia, reperfusion, renal ischemia, reperfusion, inflammation, all of those things. Those are all things that contribute to the severity of the AKI. The known preventive strategies are the maintenance of the renal perfusion and intravascular volume, avoiding venous congestion, administering salt balanced fluids instead of saline, and of course limiting the cardiopulmonary bypass times.
What about, just to stop you here, it says maintenance of renal perfusion. Is that perfusion flow or is that perfusion pressure?
It doesn't say,
yeah,
but I think it's a great point that John brought up about, I think it's more about flow. I mean, we're seeing that more and more.
I agree.
And then of those patients, 2 to 5% of them will require, renal therapy, which is actually, they saw that in the study, the article that we reviewed. It was about that percent. And then that's associated with a 50% mortality if you have to get renal therapy, renal replacement therapy.
And that's the debate of, is intermittent dialysis the 50% and CRRT a continuous therapy? Does it reduce that any? And if it does, that's really the target.
Yeah.
if it really works.
Right.
But difficult study to do ethically.
Yes.
I'm sorry, go ahead.
No, and then just the last thing, you know, even if they recover and from the replacement therapy or even mild AKI, the progression to chronic kidney disease is definitely more likely, which we saw in the previous graphic. Last thing here is talking about new strategies. And John, you may know a lot more about this, but I did find one interesting article that I hadn't heard anything about this kind of therapy, and I thought it would be interesting to talk about it a little bit. And this is a study that evaluated the effects of nitric oxide being put into the oxygenator during a bypass, and its reduction of development of acute kidney injury. And the study looked at 96 people, so a good number, you know, basically the same number as our other study that looked at mean arterial pressure. And their conclusions were that the treatment did have a decrease in the AKI that developed for those cardiac surgery patients. John, have you heard of this at all?
No, but I like it a lot. That sounds very intellectually appealing.
Yeah, it's a great article, and I can send it to you. I found it kind of at the last minute, just seeing if there were any new strategies that were out there. And
well, this is a great slide on a great topic I hadn't heard. We really need to, I think we need to pursue this, because interestingly, the 3 or 4 slides you just showed were really, really interesting, because it said 30% of cardiac surgery patients experience AKI. This same article that we're discussing, Clint said 35% of the patients, of their patients, experienced AKI, right? And they had a certain number that was control group and certain number that wasn't. And then when you had 3 or 4 slides back, it showed all the risk factors, pre-op, perioperative, and post-operative. And when you look at those, all the different things, all the different drugs that are nephrotoxic, and the dye and the cath lab and all these things, yeah, if you look there, you have preoperative, intraoperative, and postoperative. All these are risk factors that we know add to the likelihood of AKI. So, you know, as a field, we need to address this issue. 35% of the people who undergo open heart surgery are going to experience some form of AKI. Is pretty frightening, because the long-term implications, as you were showing, can be pretty dire. And I think that nitric oxide idea or things like that, we need to explore some new things, in my opinion, in our field to greatly bring this number down.
yeah, if you look at just their results, the people that had the nitric oxide treatment, only 20% developed it versus the control group, which was 41%. That's pretty incredible.
Yeah, so
that's
you know,
high.
nitric oxide is going to be a microvascular precapillary and capillary vasodilator,
right,
which is wonderfully intellectually appealing to renal perfusion and blood flow, right?
Well, really, I mean, I think all end organs, brain, bronchial circulation, pulmonary circulation, because the lungs still have to be fed, and we're taking all the blood away from them during the bypass run, right? The kidneys, the liver, I think everything.
Yeah.
You know, I think anytime you can do that, certainly, because I was thinking about the presentation that Dr. Simpkins did with his drug that modulates nitric oxide. So it takes nitric oxide from higher concentrations and redistributes it so that it's oxygen carrying as well. That was the one that was different from the other fellow that had the carbohydrate that he had turned into an oxygen carrying molecule that could ostensibly perfuse through even thrombus because of its nanoparticle size. But Dr. Simpkins had that nitric oxide modulation medication that distributed nitric oxide more evenly throughout the entire the milieu of the body. But this is interesting, but I do agree with you, John, on the fact that I think I think that perfusionists do need to start taking a more active role in addressing this concern, because it is viewed that the pump is a major contributor to this.
That's it.
You know,
That's
if we do a better job, in our delivery oxygen, we focus on delivering oxygen with flow, hemoglobin, saturation, and then we add something to turbocharge that. Let's just say the nitric oxide turns out to be a real plus. Now we're doing 1 + 1, maybe it's going to equal 3, you know, and our AKI and our perfusion of other organs, like you said, Joe, can get vastly better.
Yeah.
And, you know, I think that'd be a nice topic for the future.
Yeah, before we cut this off, can you go back to those slides of the risks?
sure. There it is.
And I just wanted to talk about this a little bit if I can, just to add a little bit of conversation to this. But look at the post-operative risk factors. And let's just go to the 1, 2, 3, fourth one down.
Okay.
And it's anemia.
Fifth one down is anemia.
Yeah, fifth one down is, no, fourth one down is blood transfusion.
Yes.
Yeah, fifth one down is anemia. So you're damned if you do, and you're damned if you don't.
Right.
What is too low? What is acceptable? When does it become too low, John? When do we, you know,
Well,
if we measure, right, go ahead, go ahead and answer.
Well, this is a great point you bring up, because in my research for a renal AKI lecture that we gave about a year or so ago, it was amazing. I found articles that looked at that exact thing in terms of AKI, and the only thing worse in terms of AKI now than somebody who's anemic is giving them a blood transfusion. The blood transfusions actually have a higher incidence of AKI than the anemia. So you're totally damned if you do, damned if you don't. You can't leave the patient anemic, right, if you start really having hypoperfusion issues. So your AKI is really caught between a rock and a hard place when you allow your patient to be anemia, which, you know, Joe, not to change the subject, but gets us back to hemoconcentration on pump and all the things that we try to eliminate, letting yourself become anemic in the first place.
Right.
Yeah.
Actually, that was something I was going to bring up as well, because really anemia is the only one that presents itself at every single category. You know, a preoperative risk, intraoperative risk while you're on pump, and then a postoperative risk. So that seems like something that, if it makes all three lists, it's got to be pretty important.
I think so too. I sent the picture to my granddaughter. She wanted to know what I was doing. Hope you don't mind. So now she knows. So I hope you didn't mind. I took a picture of you too. So with that said, I agree with that. And I think that if we measured DO2, we would know how far we could go. But I think that's another topic for another day. But I think it's worth bringing it up here. Blood transfusions are so horribly bad because we use old blood. We have a 42-day allowable storage. By then, they are fully depleted of 2,3-DPG. There's probably a tremendous amount of hemolysis that has already occurred. The potassium level and the cytokine load in those is enormous. The rigidity, or the lack of flexibility, of distortability, which is required, right? Because a red blood cell is 7 microns and a capillary is 5. And they go through one cell at a time. So it has to be able to go from 7 microns to 5 microns and squeeze through and do its deal, and then make its way on the other side, go back to its normal discoid shape, and make its way back up to the lungs, and then do it again. It has to do it over and over and over. So how much the blood transfusion, as far as I'm concerned, is because we have come to accept the use of the worst possible quality of a needed product for its intended purpose, and we use, it's kind of like we will use a frying pan without a handle on it and no oven mitt to fry an egg, no, to flip an egg or do something with a pan, or how about boil water in a pot with no bottom? How about that? I mean, it doesn't make sense. We use the worst quality, like we put in used brakes into our brand new car, and they've already been used 80,000 miles. So,
well, the blood itself is nephrotoxic for a lot of reasons, most of which you just hit on, and so the patient's anemic, they need oxygen carrying capacity for the survivability of the organs, and the thing you have to give them is highly nephrotoxic, and it's going to cause, I think you give patients blood transfusion, you measure the creatinine 48 hours later, you're going to see a spike.
Well, okay. But I don't want to see, my problem, John, is that some people have to have blood transfusions.
Yeah,
they just do. Mm-hmm. How many times have you done a case? I know it's happened to me. Maybe it's happened to you out there. The patient comes in the room, a diminutive female. You look at them. Their baseline hematocrit is already low. They're dry. So they're anemic already, and they're dry, and you have a standard cardiopulmonary setup that can only be reduced so much in total volume. The patient does not have enough blood volume to wrap the circuit, but you do the best you can, and the hematocrit is going to be 14 or 15 by the time you go on pump and give Plege, and anesthesia does their deal, the whole 9 yards, and you're told, well, let's just wait and see what it is. And then you go on pump and it's 14.6 or 15.2. So now you have an insult, and then you have to call for the blood, and then you look at the blood and it's 38 days old, and you give it. So you insult them and then insult them. So you do 2 insults at one time instead of managing it prior to surgery with fresh blood. I think that's the thing. I think cardiac surgery patients probably should use blood that's 10 days old or less. I think that should be a consideration for a research project, a study of some sort.
Our pediatric colleagues have already proven that to us.
Say that again?
Pediatric colleagues in perfusion have already proven that they use blood. I think it's less than 10 days. They will not use blood more than 10 days on their neonates and on their infants and on their pediatric patients, right?
Yeah, that makes sense. That just makes perfectly good sense to me. I didn't know that, but I take your word for it.
Oh yeah, pediatric perfusionists have I think it's a 10-day. The blood bank already knows if they not send them blood unless it's 10 days or less.
And then should we be washing through the cell saver all blood from the blood bank, red blood cells, that we give?
That's an excellent
I bet if you did a study on that, you'd be pretty impressed on the improvement if you wash bank blood first.
Mm-hmm.
Oh, that's a great
study. There's been
study.
studies on that.
See? I had one good thought today. I'm glad.
Joe, I need 5 minutes. I got to turn my camera off. I'll be right back.
Hey, well, you know what, John? Take your 5 minutes. We're gonna open the phone lines, take a 5-minute break, and when you come back, we'll see if anybody called in.
Okay.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. Levanova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. Levanova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the Wrap Venous Cannula and the EasyFlow Duo. For arterial, direct, and venous femoral cannulation, the EasyFlow aortic cannula and the wrap are available. For venous femoral access, the Levanova wrap cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of wrap improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The Levanova EasyFlow Duo Cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Yeah. Okay, and welcome back, everyone. Thank you for staying with us. And I am very excited. First of all, Tammy, I have to compliment you. That was probably one of the best. Well, where's John? I don't see him. That was one of the best. That was one of the best journal clubs slash, you know, technique review, whatever we want to call it, that I've ever experienced. That was, I don't know how you've had the time. I don't know where you found the time to do this, as busy as we've been.
We've been busy.
That was excellent.
It was interesting.
No, that was the best one we've done.
Yeah, it was very interesting.
You're going to have a hard time topping this one. John, what'd you think? That was really good.
Oh, I think they're great. I really do. I think they've all been great. I wouldn't be able to tell you which one was best, but I think they've all been just top rate all the way around. The conversation and the topics that we're able to explore once we get the article out there, I think it's just really, really good information.
Yeah, I thought this one was really, I felt this one was exceptionally Good.
Well,
I really
thank you.
did. Thank you.
It's all that ECMO time.
Yes. Okay. So it's all that time on the beach. Yeah, I know you've been. Look at her. She look like she just came back from vacation? You're tanned.
I ran today. That's
yeah,
why.
and you ran. Yeah.
Not at the beach though.
So you said I ran.
I ran. Yeah, that's why I'm glowing. I ran right
okay.
before I came.
You didn't go. What part of Iran did you go to?
Oh, stop it.
Yeah. So anyway, with that said, we'll leave the phone lines open, but let's go ahead and we'll just press on and go to my slides, and we'll talk about this what went wrong M&M. And this is a bizarre case. I'm just going to tell you up front, it's bizarre. But it's I think it's worthy of this session to have this discussion, especially in light of where we are right now in our practice kind of environment and what kinds of services we're seeing more and more of. Of course, it does involve ECMO, which, you know, seems to be a big theme with us because it's been so big lately. However, with that said, we'll just move on. So here are the case demographics. A 19-year-old African male, not African American, an African male from Africa itself. I believe he was Nigerian. 183 centimeters and 85 kilos with a muscular build. So he was fairly tall and well built. He had an active TB infection. He had a right lateral neck mass that they believed was a grossly inflamed lymph node. He presents with severe respiratory failure of unknown origin. He has severe hypoxemia. He has hyperdynamic cardiac function. And there was a decision made to put this patient on ECMO. Now, the initial presentation for perfusion, the patient was already in the operating room. A 15 French opti had been placed in the left femoral artery, and an 18 French VFEM was in the right femoral vein and advanced to the level of the right atrium. The surgeon was attempting to direct nurses to prime the Ecmo circuit. That was, from what I was able to gather, very unsuccessful. The perfusion took over. Their response time was less than 30 minutes. And from the time they were notified, and the ECMO was primed and connected to the patient. The flow was initiated, and the maximum flows with extremely high negative and positive pressures, but a normal delta P across the membrane, could be achieved with 3.8 liters of flow, is what they were able to achieve. The pulse oximeter had been inoperable and remained inoperable, assumed to be due to peripheral vasoconstriction. Patient was on pressors, but yet was very hyperdynamic and had an exceptionally high blood pressure. The patient was transferred to the ICU. The experience in the ICU included the patient remaining very hyperdynamic. The pulse oximeter, despite multiple places, remained inoperable, and the patient's arterial blood gases were a pH of 7.09, PCO2 of 30, a PO2 of 430, a bicarb of 14, and a lactate of 7. The circuit gas drawn at the same time was essentially the same. Confusion ensued. The surgeon insists something is wrong with the ECMO. The perfusionist is troubleshooting and had requested assistance from when they first recognized they were in trouble in the operating room with an already cannulated patient. So someone arrived fairly quickly, and labs were repeated with similar results. The patient's pupils are fixed and dilated. One critical question gets asked. The patient is declared dead within 12 hours. Concerns: cannula size, cannulating prior to perfusion arrival, which may have eliminated the size problem. Increased stress level for perfusion having to undo an attempt by untrained persons trying to prime an ECMO, which actually ended up delaying the procedure, getting the patient on ECMO, and hubris. I think hubris is probably really number one here. So, my question is, what happened? Tammy and John can't answer. The first caller with the correct answer wins one of these lovely, they really exist, PerfWeb cup. They're very stylish. So, if anybody can answer, feel free, and we can all you can ask me some questions if you want to. So let's take the slides down momentarily. And then, hey, John, you there? Did I get you? Sorry, didn't mean to trick you there. You didn't know you were on screen. So, so with that said, do you guys have any questions for me about this case?
Can you go back to the initial? What were the cannula sizes? 16 and 18?
No,
15 and 18.
And an 18.
Okay.
15 opti in the left femoral artery, 18 French V-fem in the right
And this
femoral
is an
vein.
85 kilogram.
85 kilogram, 183 centimeters, so over 6 foot tall.
Yeah.
Muscular build, active TB infection, big mass in his neck. And that's the reason given for VA ECMO instead of VV ECMO.
Because of the mass in his neck?
Yes. That was the reason given. So, John, you have any questions for me?
Yeah, I have some concerns, that's for sure.
Yeah, so
I don't want to ruin the caller, but let me just ask you this. Hubris on whose part?
the surgeon.
Surgeon.
The nurses attempting to set the thing up.
Well,
No. You can be Nancy Reagan and just say no.
okay.
And that's what you should do.
Yeah.
It'd be like somebody asking me, as not an RN, to go get some fentanyl out of the drawer, draw it up and give it to the patient, or make a round of potassium and give it to the patient, or start a pressor and give it to the patient, without it first being given to me by anesthesia or something else, and giving as directed. You know we don't do that.
No.
So
Joe, let me try to ask an innocuous but important question. Shouldn't mess up the caller. This is an Ecmo circuit. It was an Ecmo circuit,
Yes.
not a heart machine. And do you know what kind of circuit it was?
it was a standard access line, VA ECMO. It had I believe it was an Inspire oxygenator with just a standard line coming out of the VFEM, going in through a Revolution pump out of an Inspire and back into the patient through the femoral artery. It's just a standard AV loop. Nothing special.
Like it was a centrifugal pump with an oxygenator and lines, nothing else.
Correct. Nothing else.
Yeah.
You want to go back and look at those gases again?
Yeah.
Let's go back and look at those gases
I
again.
wrote a bunch of stuff down.
pH 7.09, PCO 230, PO2 430. That's a great PO2, but acidotic as hell. Bicarb was 14, lactate of 7. Circuit gas, basically the same. Were repeated. They were the same.
Where was the blood drawn from the patient, do you know?
Ah. John, since nobody's called yet. John, have you got one of my cups yet?
I got a 6-pack.
Did you really?
No.
No.
I actually don't have one at home, but I drank out of many of them.
I got it. Well, okay. Well,
No.
you're coming.
No, you can't send it. He has to come to get it.
Yeah.
Well, he is coming. He's coming on the 22nd.
Oh, great.
He's coming to get it. Okay. So let's just look at this. I've shown this algorithm a billion times. You have refractory hypoxemia. If it is without cardiogenic shock, the line goes straight down to veno-venous ECMO. It doesn't say anything about an option for veno-arterial ECMO at all.
Right.
If you have cardiogenic shock, then you do have that option if it is not due to hypoxemia.
Right.
You have heart failure that's due to hypoxemia, or you have hypoxemia without heart failure, VV ECMO. This is straight out of the ELSO book. This is the algorithm. This is what you're supposed to do. So despite the lesion in the neck or the swollen lymph node or whatever it was, you can put 2 VFEMs in, draw one low and add one high, the access low and the return high, and avoid the neck altogether. And they do that all day long.
So the neck was because they didn't think they can cannulate the IJ?
The only way that this person believed, according to the record, was that the return had to be in the right IJ. The access had to be in a femoral vein, and the return had to be in the right IJ for VV ECMO. That was the only way it should be done.
There's many other choices.
And so the decision was predicated on that, and so the decision was made by that same person to instead do VA.
So the choice was VV with IJ or
Return.
return, or VA. Those are the only
With-
two choices that they
Those
thought.
are the only two choices.
Okay.
So, I've also shown this slide, I don't know how many times. Never be this guy. Never use VA ECMO with peripheral cannulation for pure pulmonary failure when there is no LV dysfunction. I cannot stress that enough.
But why, Joe?
Because I've seen it. I've seen the devastating effects of it firsthand. So we can look at this diagram and we can take into consideration as a little help in case somebody decides to call in, because John, you haven't won yet. You haven't actually said it. I'm still giving somebody a chance.
No, I know what it is, but go ahead. Yeah.
But I'm going to go to the next slide, because remember, the PO2 is 430. It was a very high PO2. It was a good PO2. We all know what this is, right? Okay, we've all seen this. So don't take my slides down yet. So I'll give everybody one more chance. What is the magic question? What question got asked that made everybody realize why the patient was dead in the head with a PO2 of 430? Go ahead, John. What's the question?
Where did you draw your blood gas sample from?
Where the arterial line pressure was being measured from.
Where is
Where's that?
Where is that?
The contralateral femoral artery.
Well, it's very oxygenated down there. Too bad the brain isn't down there.
Exactly. So this whole thing, and let me just go to that diagram again. I'm just going to draw it out and just use my little magic arrow here. When I move this,
There it is.
where'd it go? Is it up, down?
Yeah, there it is.
There it is. Okay. So they have their access catheter here in the IVC up by the right atrium. They have their return here with a little 15 French with a super hyperdynamic heart pumping blood probably at 12 liters or more out of the left ventricle up the aorta with absolutely no lungs. So all blood returning to the heart is blood that is totally desaturated and then going through the lungs and receiving no oxygen, returning to the LV, getting pumped out, perfusing all of this from about here all the way up to here with nothing but deoxygenated blood, and the femoral arterial cannula that's here pumping is drawing gases from here. So it's going up and down and maybe pumping up to here. Maybe with a 15 French at 3 liters with somebody that had a blood pressure of about 200 with a straight up and down upstroke because they were on pressors on top of it for some reason. Never really understood that. So going back to my final slide, that's what it looks like. Deoxygenated blood makes its way to the LV, gets pumped out. There's a mixing cloud where it's purple, and then you have red here. And if you measure your arterial gases from this site, even if you measure it from the left arm out here, you still could be missing the left carotid and the right carotid through the innominate and so forth, because your mixing cloud could be right there. This could just be a purple zone. So never use femoral arterial, peripheral arterial cannulation for your VA ECMO with a patient with a hyperdynamic, with just normal heart, but pure LV failure. Never, never, never do it, and this is why. It's the most insidious, in my view, of morbidities associated and ultimately mortality associated with ECMO. I think it's the most insidious thing to ever have happen, and how it is not readily recognized in today's day and time baffles me. So that's my presentation. If anybody wants to call and comment on it, tell me about an experience they had. I think phone lines are still open. But Tammy, I'm going to start with you. What's your thoughts?
Well, a couple. Sounds like perhaps the surgeon putting in the ECMO didn't have a lot of experience, perhaps, with the ECMO.
Mm-hmm.
And 1. 2, I think this highlights that perfusionists aren't just there to monitor, follow, whatever, that we actually have some valuable insight into the therapies that we are trained for, and better to do other things to the patient while you're waiting for the perfusionist to get there, I mean, than trying to proceed ahead. Because you're right, there were a couple stop points. Could have definitely talked about cannulas are too small. Why do you want to do VA ECMO? That conversation hopefully would be had. And the third, trying to prime the circuit, which I'm sure was completely full of air, airlocks, all of those sorts of things. And if you didn't have, you know, if you'd already disconnected it, that's going to, you know, from your loop, that's going to be even worse because it doesn't sound like there was a manifold or anything to try to de-air that way.
It was challenging, absolutely challenging.
Yeah.
And I think that what probably bothers me most about this is that,
or even the fourth spot of where was this, where are we going to draw blood pressures if we're going to do this? Is it the perfusionist who caught this?
it was.
Yeah.
And it would have, I think, been caught sooner had they been involved in the case from the beginning.
Yeah.
Because they got thrown into it when it was in process and assumed that it was coming from the right radial.
Right.
They made that assumption from the beginning.
Right.
Oh, we have more. You gonna leave both on, or just leave both on, or in case one comes back on? We have to fix these mics.
So, Joe and
You're
Tammy,
burning my mics out.
Joe, you've tried to send this message to our viewers. Like you said, how many times you put a couple of those slides up. You've tried to send this message to our viewers probably a half a dozen times or so.
Mm-hmm.
And I was just thinking, you know, like we always try to do, we try to give our viewers, if there's one thing I can take home and be a better perfusionist tomorrow. So let me take a stab at that. And it's what you're trying to say in maybe a little bit more of a compact way. So if you're on an open heart team, or let's say you're on an ECMO team, even if you're not the perfusionist, if you're a nurse, PA, physician, anesthesiologist, when you hear the word ARDS or poor oxygenation, whether it's a food aspiration, a drowning, any type of flu, A, B, or unknown, TB, COVID, unknown ARDS, when you hear that the person's lungs are not functioning, the first thing you must say to yourself is, we have to oxygenate his blood before it gets to the lungs. However we're going to do that, there might be a half a dozen ways you can think of that you're comfortable with, you're not comfortable with. We have to oxygenate the blood prior to it going to the lungs, because when it goes through the lungs and it comes out the other side, if we're relying on these lungs that are in ARDS to do that job, it's not going to happen. And what comes out of the left ventricle is going to the brain.
Mm-hmm. Mm-hmm.
So if you're going to do VVA or something, that might be okay, but you have to have that VV component in there 99% of the time. And especially when you go fem-fem, you've changed the whole dynamic of your Ecmo circuit, perfusing all the way up retrograde to the aorta, to the brain, against any kind of beating heart.
Mm-hmm. Absolutely. Now let me ask you this, if I can. Can you throw that slide up?
The Harlequin or?
No, that one.
Oh.
Thank you. So, but I want to take it just a little step farther.
Okay.
Other than just VV, John, and you're probably more experienced this than I am, are there other cannulation strategies added on to that which you think could have benefited this patient? Because even VV, my concern, let's say we had normal cannulas and we were, let's just hypothetically say we put in a 31 Avalon, or 33, let's say 33 Avalon. This guy was a big guy, and he probably would have accommodated it pretty easily. But let's say we had a 28 or a 30 and a 26 return, and they were, you know, offset with access low and return high, whatever. Would 6 liters have been enough for this kid, given that he's muscular, high O2 extraction rate, probably a cardiac output of 12 liters? I'll bet it was 12 liters. Would that even be enough? And what other options would we have had?
Oh, No, you've got a great graphic there. So if you look at your graphic, look at the left subclavian vein. You could put, like, if you had a mass on the right neck and you didn't want to go into the right IJ, you have a left subclavian vein. We use this all the time. You can put a Protect Duo or an Avalon almost down into the top of that right atrium and do a VV straight from there. Then if you're flowing 6 liters, 5-6 liters, and it's not enough, you go down to a femoral vein and you add another return to the patient, oxygenating up the IVC. And then if you wanted to go arterially and you didn't want to use a femoral vein, you can go into that axillary right there as well, either side, and do a VVA.
Mm-hmm.
Or a
even
VVVA.
Yeah,
A
VVVA.
Yeah,
Yeah.
VV, yeah.
VV-VA.
Right.
Yeah.
Because the dash is where, you taught us this, the dash is where the oxygenator goes.
Yeah. Now, would that
So,
be, would you do
you know-
that, if you, let's say you did that, John, let me interrupt for just a second. Would
Sorry.
you would you do a second circuit?
That's a great question.
The first thing you would try to do is give esmolol and slow down his hyperdynamic activity. That's the first thing you would try to do. Esmolol is wonderful. It slows the heart rate nicely. It's very, very short acting. And, you know, he's probably hyperdynamic because you've got an unknown infection. You said unknown, probably septic, right? And then he's got some TB and also an unknown ARDS, maybe on top of that. So, you know, you try to slow them down. Then you need to address the sepsis. But if you cannot slow him down enough from, let's say, 12 liters down to 9 liters, but now you're flowing 6 liters, that would be enough. You're flowing 66% of his cardiac output. You're oxygenating on the venous side. As long as you're above 40, 50%, you're going to have a pretty good, decent PO2 and usually a good CO2 also going to his arterial side.
Well, do you think his hyperdynamic state would have improved
If he had
with
oxygen?
oxygenation?
Yeah, that's what I was
Yeah,
thinking.
most likely, yes. Yeah, absolutely.
That his brain PCO2 was probably vastly different, along with the PO2, obviously. And so his drive was probably just through the roof.
Yeah.
You know, and all of his other sensory, you know, information was heart pump. You know, so I'm sure that when he was young. I mean, I think anybody that would have been 50 years old would have succumbed much sooner.
Yeah.
I worked with an anesthesiologist one time many years ago who used to say, the greatest drug there ever was is oxygen.
I just said that today.
We need shirts.
Oh, really?
Yes,
Got oxygen?
got oxygen. I like it. Well, they have oxygen bars.
They
Yeah.
do.
You can go to oxygen bars and suck on, you know, I don't think it's much though. I think it's only like 28% or maybe not even 30%, is it? It's not very
You
much.
look at me like I've been.
It's not like they give you 100% O2. It's pretty low. It's kind of like nitrox, you know. It's a little less. It's a little more oxygen for a little less nitrous, so that you can go diving longer because nitrous is inert and oxygen is not. So it helps you be able to stay at deeper depths. Deeper depths. I guess that sounds redundant to me. I don't think that's the right way to say it. At greater depths.
There you go.
There you go. While you're scuba diving for a longer period of time. They call it nitrox. So I think that's only like 24%. It's not much. You know. You dive, don't you?
Yeah, yeah. But you got to be, when you're starting to get into nitrox, you're beyond recreational diving. You're going greater than 90 feet, and recreational diving stops about 90 feet, and you're talking about doing some things where daylight is very hard to find. Everything is, you know, darkness just about, and you have to be decompression stops. You better know what you're doing.
Yeah, well, I was in Galapagos, And it was, I just don't remember the nitrox. I passed the test, but I don't remember it anymore. And it was some pretty rough diving. There were some big time currents there. It wasn't easy. And the water was cold. You're in the Humboldt Current. And it's on the equator, so you think it's just going to be warm. But it's not. The water was like, on the surface, was like 56 degrees. It was cold. You had to wear a 7 mil wetsuit. And it was, you know, I mean, I was huffing and puffing just putting the stupid wetsuit on. But it was fun. It was a lot of fun. And we didn't really go that much farther than 100 feet. I probably went under 100 feet for a couple, probably 110, I guess. Somewhere around there. But there were some interesting creatures. Those whale sharks are big, man. I'll tell you what, saw those, you know, they're 26 to 30 feet long. I mean, they're big animals. It was some fun. It was a fun trip. And then you see these at like 40 feet, 30, 40 feet, you'll see these birds, the flightless cormorants, and they'll dive down and you'll see them, you know, just swimming around and pecking at the rocks looking for, you know, shellfish and stuff like that. And then they'll go back up. But you see a bird basically, you know, swimming along. It's kind of weird.
What did you drink?
What do you drink? Oh, this is just tea. All right. So apparently I'm off topic. So any
protection team is bringing you back in.
Yeah. Okay. John, any final thoughts?
Well, yeah. I mean, the other thing is on this case, you know, I don't know why he put in on such a big guy such small cannulas. No wonder the pressures in your Ecmo circuit were so high.
Yeah.
You have an 18 French, you're trying to drain a guy. You got 15 French arterial cannula. I think, you know, below 18 French is considered pediatric range. So I don't know how we got a 15 French from arterial cannula. So you can't even flow with your Ecmo circuit, and yet you're trying a hyperdynamic fellow who's pushing the opposite direction on oxygenated blood. I mean, who knows? Your mixing cloud was probably way down by the kidneys.
Yeah.
It was so low.
Let me ask you this though, for the, you know, to add to your final thoughts, I'd like you to address this. Your oxygenator. So you said you got to slow that heart rate down because the oxygenators, I think, only rated at 7 liters.
Yeah, usually 7 liters.
So it would have been tough to be much higher than that. So you think this should have been done with, first try it with one circuit before you try adding a second circuit?
That's exactly why I was asking that question, is depending on what amount of liters that we need for this big muscular guy, do we need a second oxygenator?
And when you do that, John, do you increase it? You're increasing the surface area. So are you therefore also increasing the thrombogenetic profile? Are you doubling that as well? Do you consider that you have to add more heparin?
The first thing you would do is get your normal VV approach accomplished. Let's just say that is an Avalon. Let's say the guy didn't have a neck mass, whatever. You put in an Avalon and you're supporting, now right off the bat, whatever it is you're flowing, even if it's 4 or 5 liters, it's a heck of a lot better than he was 5 minutes ago, right? So
Agreed.
So you've made a great step in the right direction, and things are got to be a little bit better anyway. If it's not nearly enough, you go down to your femorals and put in, like you said, Joe, a short fem and a long fem, and set up another VV circuit. Now, generally, we would wire that into our present circuit and see if we could flow. You know, even though it's rated for 6 or 7 liters, it'll work higher than that. But anyway, that's an awful lot of VV support. And then you should slow your patient's heart rate down, and then the two start to come together quite a bit. And usually, I mean, it's going to be pretty unusual that that's not enough support. But in the couple cases that we've had where it wasn't, then we took the VV part and put that on an ECMO device, and took the Avalon part and put that on an ECMO device. Now you can flow 5-6 liters on both of them.
Yeah. So, and did you find that to require one additional heparin? Did you, I mean, I don't think you would, but did you notice an appreciable, you know, alteration in hemodilution, more bleeding? You know, I mean, is there anything about that double circuit that you found fluid management control, anything that you found to be increasingly difficult as a result of two circuits?
Well, the first thing was you talk about, all cannulas are going to have some mixing. So all these cannulas are in the patient. They're not far from each other now, right? Mm-hmm. So we have mixing within its own ECMO. Then you have mixing ECMO to ECMO. How much is actually making it to the patient properly? So that was a mystery you can never quite solve. And which ECMO do you turn up higher? If you want more support, do you turn the VV Fem ECMO higher? And does that negatively affect what you're trying to do up at the Avalon? So that part was very interesting. I don't recall having to modify our heparinization aspect of it very much, but you can guarantee that your Sears response is going to be heavy duty, because your artificial surface exposure is, it's double. That oxygenator has a lot of surface area coming through there. Yeah. You have a lot of things going on, and you have a lot of intricacies going on with the cannulas bumping up against each other. Is there even enough room when you start getting into the atrium? You're trying to get to the atrium. You have cannulas side by side. Yeah, it gets real interesting on the flow characteristics.
I think that as far as which one you would turn up more, and or they're the same, or one's less and one's more, I think we might be able to get some information using our recirculation device, because you could measure what's coming back to the circuit on each one at varying, flows, and to see if what John's talking about, if you're returning from the one, let's say the Avalon, and depending on the position of the access for the VV, is it just is it sucking that back, or because it's too high or too low? Do you know what I mean?
I do, but I think that would be very challenging. I think it could be done if you did them each independently with each one paused, because you're going to have some recirculation going down one and some of that return blood going down the other.
Well, we would need two devices, I think, right? Two recirculation.
And do them simultaneously?
Yes.
Maybe, or if they were wide far enough up, do them proximal to the centrifugal pump, as long as you were on a single line. Then I think it would give you combined. Yeah. But I don't think it would identify which one was necessarily the bigger culprit, because I think they're both going to influence the other. So I think if you keep them both running, your combined may look one way to you, and you think, oh, because you're not going to know which one the recirculation came down. You're just going to be looking at another. You're going to go, okay, well, it's combined. Let's say it's 42%. That's too high. Yeah. But which one? So you would have to check each arm individually and cancel out the other circuit. So the VV, if you're going VV dash VV, which is what we're talking about, you'd have to go VV, check that one, clamping the other one out, and then go VV with the other one, and then measure that, and look at each circuit individually to make a decision about what you need to do, if it's acceptable or not. I believe.
Then once you turn them both back up, when you turn them both back up, that all changes again.
Right.
Yeah.
Right. Yeah, I think I call those exotic circuits.
Yeah.
And I think when you get exotic circuits, the best way to check whether you're being effective is to measure the only place of VV ECMO. Where is it, everybody? The only place you should ever measure the arterial PO2 on a VV ECMO patient is from what site? Anyone gets the answer, Tammy and John are sending you on an all-inclusive, fully paid trip to Barbados? Nope, no callers. Where's the only place? I know I didn't give you time to dial because they're not sending you anywhere. Where is it? The only place you should measure.
The answer is the same for a VA ECMO, actually.
Yes, good point. Where is the only place
Are you going to raise your hand
you
anymore?
should ever measure from your arterial PO2 when you're on ECMO of any kind, but especially VV? Where?
Is it the left side?
Where?
Radio.
Where? Don't mess with me, Tammy. The right wrist.
Showing it to us.
Yeah. Right brachial.
Right. The right radial. Well, it could be the right brachial.
I said brachial.
Oh, you did?
Yeah, said right
Okay.
brachial.
It could be right axillary.
Okay.
Yeah. It'll be in the right
The
arm.
right arm.
Yeah.
But I
Very
think
good.
You were given a big clue.
Oh, was I?
You were.
I didn't mean to.
Yeah.
Okay. All right. So, okay, you've had your final thoughts. Did you have anything you wanted to add besides what you said for final thoughts? John?
I'm good. I'm good. Thanks.
Miss Sparacino?
I do have a couple final thoughts, and it goes back to our last journal club when we talked about the importance of, as perfusionists, having protocols readily available, especially if you're maybe not experienced with certain procedures. Could you click back to that flow chart?
Yes.
I think
There it is, right there.
Yep. That would be something that would be in my ECMO protocol book. Because
Yes.
you arrive on the scene, they're VA, what's wrong with this patient? You could look there if you don't have it right in your mind. You know, you're stressed out, you arrive late, they're already cannulated, they've messed up your circuit, it would be right there. But wait, this says this, and then you could have that conversation.
And you have something to actually show them.
Right. This is
I agree. I think everybody should. If you can't find this, there's the just so you know, the reference for it is right there. You can look it up on the Googs, and you can download it and print it. It's free, and you can put that in your book. You can hang that, laminate it, and
could be
put
on
it
your-
on your ECMO cart.
right. Exactly.
Whatever you need
ECMO
to do.
machine. Yep. Good point, Joe. Good point.
I think that'd be a good thing to do
You know,
for
just
everybody.
like I think most ECMO machines say, like, is the oxygen on, heparin given? This could be on there too. Quick reference.
Yes, yes. I think that it. I think it should be.
And even, you know,
it's a decision algorithm.
right, and even cannulation sizes for, you know, ranges. So you could have something printed. So when that doctor says I've cannulated with a 15, you know,
That's another thing. What's our maximum flow through that? Those
Right.
exist too.
they do.
I think we should take that into consideration as well. Okay, on the slides, we're good there.
Yeah.
Well, can I bring up something else? Because I need some time filler, and I need to bring up something else if I may.
Sure.
So I had another experience here recently. And John, I want to ask you about this. Had a patient with that's relatively young, female, COVID-19, pulmonary failure, normal cardiac function. ECMO is working well, but getting some chatter, seems to be volume-associated chatter, but a ultrasound of the right IJ showed a well-distended right IJ. Didn't appear to be hypovolemic at all. And a decision was made to take the patient to the cath lab and put in a Protect Duo second circuit. There's no neck access complications. Obviously, they did it through the neck on this. They didn't use the axillary or subclavian vein. I guess subclavian vein would be more appropriate for that.
Where was the first cannulations?
Fem-fem.
Oh, fem-fem.
Fem-fem, yeah. First cannulation was dual femoral cannulation.
FMBV, and then
Yes.
they're going to, okay.
And was, you know, I mean,
So now they're gonna put
was
this in the IJ.
Yes, was pretty supportive, you know, was running, you know, they just had very little native lung function. Their native lung function isn't good. And they were certainly VV ECMO dependent, but with ventilatory rest settings doing well on ECMO with a saturation above 97%. So doing well. And PCO2s were a little high, but they just happen to run their sweeps very low and let their CO2s be high and let them compensate metabolically for it. They all run very high bicarbs. But they decided to use a second circuit and a Protect Duo. Ultimately, there was no real discernible benefit to me post-procedural.
What was the reasoning that they wanted to do that?
I never really got that answer.
Okay.
I just was wondering what I was missing. The patient did not have right heart dysfunction. They had no cardiac dysfunction at all, and relatively young. So what did I miss? What do I not understand?
So they were just trying to increase total flow?
I believe so. What I thought they were going to, well, again, the access catheters seemed to be chattering and had been chattering for the past 24, 30 hours.
So they thought they weren't getting enough drainage to be able to flow more?
Yes, and it was, it was becoming somewhat intermittent, and it did resolve with the fluid administration, but it never really stayed long enough, and it would just return.
It sounds like a cannulation position issue.
Maybe, and that's kind of what I thought too. I thought this patient would have benefited from just converting to an Avalon, a bigger Avalon, so you could, sit them, bend them, and sit them up. They did keep this patient in a reverse Trendelenburg position, but I think just sitting them up is a better way to accomplish that, I think. But that's not what they did. This is what they did, and I'm just curious what I missed, because I didn't understand. It didn't make sense to me, and I wonder if you had seen this before.
Yeah, I mean, you're going to see it if the cannula is too small, or if it's up against the wall. Maybe the person's a small person with a very, fairly narrow IVC or something. But it sounds to me like the cannula could have been advanced further and got into a larger drainage, diameter area or something. And they put in, so they had fem, VV, and they were having drainage problems. They could have possibly done something with a. They could have possibly done something to increase the drainage, maybe up in a left subclavian or something. But maybe they tried to put a larger Avalon and started fresh, a much larger cannula, positioned it properly, and then started fresh with that, and then see how well they could have flowed with that. We could have tried something.
Yeah. Although,
I have a question. So it's not draining for enough flow.
Well, it's just every once in a while is intermittent. They didn't think she was third spacing, but I felt like she looked puffy to me. So I do think she was third spacing, although they were treating with her albumin. So, they originally thought she may be bleeding, but again, but I had to say I was impressed at the distension, the size of the right IJ. It was significant. I mean, it was nice and puffy.
Well,
it wasn't collapsed.
If they think that it's a volume thing and not a cannula position thing, then I don't see how the additional access is going to help them. You just need more volume for that particular access. If you think it's a cannula position thing that you can't fix, then just adding another access. Why do we need the other return?
Yeah, I don't know. I didn't understand it. I still don't understand.
You're draining from a short femoral venous cannula way down low and returning up the long one, trying to aim it to the right atrium. So if it was distending on the right AIJ, that's because the cannula was too far up and you were shooting return past the right atrium, it sounds like to me. But
I didn't
if
think
you
about
have
that. Oh, yeah,
the
that's a good
femoral
point. I didn't think about
cannulas side by side, the one trying to drain is up against the longer one and up against the side wall. And
Well,
you're having a hard time draining.
Yeah.
Yeah. So,
I didn't
and
think about
also,
that.
if your cannula, your return cannula is advanced too far, then when you put in the additional drainage cannula, you're probably just going to recirculate, right?
Yeah, I think an Avalon would have been the smarter thing to do because I
The
think
single
that
Avalon and
yeah,
discontinue the fem.
I do. I think that the IVC, the SVC and the IVC diameters much better than the ilio low IVC, area for drainage.
Yeah, I mean, that's why we do we do a FEM, a right IJ, because when you start putting two in the same, side by side, like what you're talking about, you can have side holes getting up against each other and not draining well, and then you have a little bit of a low volume and the collapse of the IVC around the one that you're trying to drain, and
especially-
you kind of get stuck.
Yeah.
So if you do just a femoral venous right IJ, then you have, those aren't fighting each other side by side anyway.
Yeah, I agree.
In addition, you said it was a woman and she was small, so I bet that
She wasn't. She was a little bit bigger person, not morbidly obese, but maybe a little on the chunky side.
well, no,
but
not
but
weight
in
wise.
a small person's body.
Right, so
Yes.
she's a petite person who is overweight.
Yes.
But the overweight's not going to help you with probably
So-
the size of your veins.
Right.
So it was probably the cannula, like what
So
John
what
said
we would
there.
have done there, Joe, so what we would have done there is taken an x-ray, make sure it pulled the long cannula back into position, see what that did, and if that didn't work, we would have taken a right IJ and put that down in the right atrium and then drained from the other two that were in, the original two. Those would have been the drain. So you have a high drain and a low drain and return back to the right IJ into the right atrium. That's what we would have probably done.
Yeah, I think that would have made a lot more sense than what we did. Okay, so are you done with your final? Did you do your final thoughts?
Yeah, I was.
Okay.
I circled back to the protocol books and references. So you back yourself up if you're going to need to go, present information that it sounded like that surgeon might not have been receptive to hear,
It doesn't always have to be a surgeon.
or whomever.
Keep that in mind. You never know what you're going to get. It's like Forrest Gump, the box of chocolates thing. Okay, so it's my turn for final thoughts very quickly, which are PerfWeb 43, Saturday, September 12th. We're going to have a really neat pro-con position. Dr. Samir is taking the proning condition, and this is while on ECMO. And Dr. Joy Thula, who we've met before, wonderful man, incredibly intelligent, is taking the con position on proning, and he and Dr. Samir are going to battle that out right here on the stage. Then we have John Ingram, our own John Ingram, giving I think this is going to be the greatest lecture we've ever heard, the 10 most common mistakes of new ECMO programs.
Oh, that's going to be great.
This is going to be really good. And then following that is going to be lung transplant, a new lease on life after COVID, which is going to be Serena Patrick, who is the transplant nurse coordinator from Methodist. So she is very, very impactful, very influential in the lung transplant arena, and we'll be talking about lung transplant for COVID-19 patients. So I think this is going to be a great session, a great opportunity. If there's anybody out there that may be close locally and you want to come and be in the studio audience, because we're going to have a big party afterwards. John Ingram is going to be here, so it's a party whenever John shows up. And we're going to have a lot of fun, and you're welcome to come. be a part of being in the studio, live studio audience, with then participating in the party afterwards. So if you want to do that, just reach us via our email, info@mediweb.us or contact@perfusioneducation.com, whichever one you want to do. But this has been a great session. We're all getting beaten up. We are as busy as I didn't think this was going to happen.
You didn't think we'd be this busy?
No, I didn't. I did not think this was going to get to where it has gotten. I have to admit, I was hope springs eternal. And, you know, I think we were prepared, but I think that it has really shown me how you really cannot be totally prepared for something like this. This has been a lot of curveballs. This is having 4 major league pitchers throwing fastballs, curveballs, knuckleballs, and sliders at you, wearing no protection and no glove. It's been a challenge. So I'm sure some of our colleagues out there in web world are experiencing the same thing. And if you are, my gratitude for all the work you're doing. Tammy, my gratitude for you, because I know how hard you're working and still put together one of the best journal club lectures on a topic that I've ever heard. I appreciate it. John, you're just always willing to participate despite working tremendously long hours from across the borders in Disneyland. And we appreciate you so
Disney
very
World.
much.
It would be
Disney
World.
World, yeah, exactly, sorry.
It's
Disney
crazy.
World.
It's crazy busy here around the clock, Joe. We got 14 ECMOs going.
Yeah.
14.
That's just crazy. And but I appreciate both of you for your willingness to do this. We are PerfWeb, and you guys are the foundation of this whole program, and I can't thank both of you enough. And I know you're coming on the 12th, and we're going to have a lot of fun. I hope you and Mike are coming too.
Hopefully.
Yes, I hope so.
Yeah.
If you are, we're going to have a party, and I might even bring out my dipping toes.
Oh my. Before we get into that, or maybe instead of, we're going to have a journal club prior to this one though, yes? I think we're having it on maybe the 7th?
No.
No, we don't have one before?
No, we don't have one until Monday, September 14th.
Oh, so it's right after.
Yes.
Right
Yes.
after.
Right after.
It's right after. It's
right.
the Monday after the 12th.
All
yes. So we don't have one before.
Okay.
No. This is it
Oh,
until.
because of Labor Day.
Yes.
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 Okay.
Yes.
All right.
And I figured you probably deserved a little break. A wee break.
We break.
Wee break. All right. Everybody, we'll see you September 12th, and then we'll see you September the 14th, and then we'll see you September 24th, and then we'll see you October 5th, and on from there. So check out perfweb.us. Thank you for your time and attention. As always, we appreciate the support. The word has gotten out there, and you know, the program is the program, but the program doesn't exist without an audience. So thank you all very much for tuning in, and we wish somebody would call in. And if anybody ever calls in for any reason whatsoever, you'll get a darn cup. All right, good night.
Good night.
Bye.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. Levanova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. Levanova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the Levanova wrap cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of wrap improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The Levanova EasyFlow Duo Cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out, this totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.